Assalamu alaikum everyone. The next topic of discussion is chickenpox, which is caused by varicella zoster virus. It primarily occurs in children, and it's caused by varicella zoster virus, which is also known as human herpes type 3 HHV3 virus. It can be transmitted through airborne droplets, direct skin contact, or transplacental. It's highly contagious 2 days before and up to 5 days after the onset of the rash. Latency should become latent after the primary infection and reside inside the trigeminal or dorsal root ganglia. Risk factor for the infection. So, individual with any of the following factors are at severe primary infection if they have no evidence of immunity, like having a patient having age greater than 12, immunosuppressions, pregnancy, chronic skin or lung diseases, long-term salicylate therapy, for example, aspirin, and infancy. These all are the risk factors for severe infection. Now, how the patient will present? So, its incubation period is about 2 weeks. There will be prodromal phase, which will be about 2 to 3 days prior to the onset of the rash. Exanthum phase is characterized by 250 to 500 severely pruritic lesions in the varying stages of development. This is the main point, that the lesions will be in all stages of development, like papules, pustules, vesicles, and crusted lesions. So, all type of lesions with different stages of development will be present. For example, lesion stages like papule, then we have superficial vesicle filled with clear fluid on the erythematous base, which give a dewdrop on rose petal appearance. So we will have lesions with clear fluid, umbilications and crusted pustules that will fall off after 1 to 3 weeks, often leaving a depressed base. Skin involvement shows lesion first manifests centrally, like face, scalp, and trunk, and spread to the extremity. The rash is ultimately distributed across the body, with highest concentration in the central area. The oral and urogenital membranes are affected. Ocular involvement may also be present, but palms and sole are spared. Features of the severe varicella infections are prolonged high fever like greater than 1 week, prolonged eruption of vesicle for more than 5 days, and signs of thrombocytopenia including hemorrhagic skin lesions. Symptom of visceral dissemination like encephalitis, pneumonia. These all are the signs of severe infection. Latent phase. So following resolution of the active infection, VZV remain latent in the sensory root ganglia. It can later reactivate, leading to the shingles. So the signs of severe varicella infections are prolonged eruption of the vesicles, which are sometimes hemorrhagic, high grade of fever, and dissemination of VZV to the brain, encephalitis, liver hepatitis, and or lung pneumonia. So this is the image showing vesicles in the central area on the trunk filled with clear fluid. This is the image showing diffuse rash seen in various stages of evolutions, giving a starry sky appearance. So these lesions are in varying stages of their development. Some are vesicles, some are pustules, some are papules, while some are crusted lesions. This image also shows various stages of rash, mainly vesicles and pustules, present on the trunk and also on the extremities. This image also shows macules, vesicles, and papules on erythematous base. And this is the image which show a dewdrop on a rose petal appearance. These are the vesicle filled with clear fluid on erythematous base. Diagnosis. So typically a clinical diagnosis. Confirmatory studies are usually considered in the following cases, like suspected VZV infection in patient with no rash or uncharacteristic rash, vaccinated patient with suspected varicella infection, and patient with immunocompromised contacts. Confirmatory studies of PCR is preferred test for active infection, which detect VZV DNA. Serology, IgM, and IgG detection. Serial IgG is checked to detect the infection, and IgM positivity show the recent infection. Well, culture, but it's not usually used because it's not useful. And teasing smear, which is not specific for VZV because it must be positive in HSV infections. Chickenpox is usually diagnosed clinically, obtain lab testing in case of atypical rash or in case of severe infection. Additional studies consider in severe varicella infection which depend on the clinical feature. So bacterial superinfection of the lesions, for example pneumonia. So for pneumonia, chest imaging like CT or chest X-ray and meningoencephalitis can occur, in which PCR of the CSF and MRI of the brain can be done. Differentials, so we have these all differentials for the varicella zoster infection like herpes zoster, HSP, enterovirus, widespread bullous impetigo, monkeypox, and adverse reaction to smallpox vaccine eliminated. Treatment of the VZV, so start supported treatment for all patients and assess the indication for antiviral, like patient with severe infection or having risk factor for the severe infection. If indications are present, so determine the duration of the symptom. If duration is less than 72 hours, so initiate immediate antiviral therapy. Supported treatment include treatment of the fever and pain with acetaminophen. Don't use the NSAIDs. Pruritus, so general advice, and there are medication. And medication you have topical like calamine lotion and pramoxine gel, and oral antihistamines. Avoid use of aspirin and other salicylates in children with chickenpox because the risk of Reye syndrome. Antiviral therapy for VZV infection, so it's used for high risk patient only. Indications are severe VZV infection and risk factor for the infection. Recommended treatment, so begin antiviral therapy as soon as possible, ideally within 24 hours. Immunocompromised individual, neonates, and are those with severe infections who give IV acyclovir. Immunocompetent individual are an individual with non-severe infection, so oral acyclovir or valacyclovir. Patient with non-severe infection and no risk factor for severe infection do not require antiviral therapy and can be managed with supportive treatment only. Complications, complications are more common in adults as compared to the children. Skin complication of bacterial superinfection, reactivation of the VZV result in shingles and scarring. In central nervous system, we can have development of the acute cerebellar ataxia, encephalitis. In lungs, pneumonia, and in fetus, like chickenpox during pregnancy, leads to congenital varicella syndrome. Prognosis. So, in healthy children, chickenpox infection generally has a benign course and heal without any consequences. Residual scarring may occur because of excessive scratching or bacterial superinfection. Immunosuppressed individuals are at greatest risk for the disease taking a generalized or even fatal course. Prevention of the chickenpox, so we check the evidence of VZV immunity. Any of the following will show that the person is immune to the infection, like documentation of age-appropriate immunization, lab findings that confirm prior wild-type disease, or serologic evidence of immunity like positive IgG antibodies, attestation of the past varicella or herpes zoster infection by healthcare provider. So these all will show the evidence of the VZV immunity. Varicella vaccine, so general principle, it consists of 2 doses and it's a live vaccine, attenuated vaccine. Available vaccines include a single antigen and a combined measles, mumps, rubella, MMR vaccine. Recommended for all individuals without evidence of VZV immunity who have no contraindication to live vaccine. So it's recommended to the individual without evidence of VZV immunity. Adverse effects, so if it's given at the age of 12 to 23 months of age, so there will be increased risk of febrile seizure and also vaccine associated chickenpox rashes. So these are the adverse effects. Post-exposure prophylaxis. So post-exposure prophylaxis is recommended for non-immune individual who are exposed to the chickenpox or shingle to prevent disease onset. If symptoms develop following exposure, so initiate treatment of varicella infection regardless of whether the patient received post-exposure prophylaxis. So if the symptoms develop, so initiate the treatment. Determining post-exposure prophylaxis. So this is the table which give a summary for the prophylaxis. For the immunocompetent individual having evidence of his immunity, so prophylaxis is not recommended. While the immunocompetent individual with no evidence of the VZV immunity, so prophylaxis is required with active immunization. Immunocompromised individuals, so prophylaxis is usually only required for patients who have received a bone marrow transplant, and passive immunization is recommended. And immunocompetent with no evidence of VZV immunity, so post-exposure prophylaxis is required with be done with passive immunization. Here we have active immunization, while in immunocompromised patient, passive immunization is given. Active immunization, so active indications are immunocompetent patient greater than 12 months of age with no evidence of VZV immunity. Recommended prophylaxis, so give within 5 days following exposure, ideally within 3 days. Prophylaxis is not recommended for healthy individuals who are either too young or who are exposed to VZV greater than 5 days prior to evaluation. Passive immunization, so indication are individuals with no evidence of the VZV immunity who are immunocompromised and pregnant. Neonates, if the mother was symptomatic 5 days before or 2 days after the birth. This is the period of high fertility for the neonates because their immune system is not mature and the mother was not prepared to not ready to prepare the antibodies which can cross the placenta and prevent the neonate from the infection. Hospitalized premature babies, so those who are born less than 28 weeks of gestation or with a birth weight lesser or equal to 1 kg, are those born with the greater or equal to 28 weeks of gestation to a mother without VZV immunity. So these are the indication for the passive immunization. Recommended prophylaxis give as soon as possible within 10 days following exposure, ideally within 4 days. Preferred reagents are varicella zoster immunoglobulin. If it's not available within 10 days of the exposure, so IV immunoglobulin are given. So varicella zoster immunoglobulin is preferred, but if it's not available, so intravenous immunoglobulin IVIG is given. So that's all about chickenpox.